Good evening to all. At the outset, my sincere thanks to Professor Duseja and Charles for the kind invitation to deliver a talk on the Beyond MELD, emerging strategies and technologies for improving mortality prediction, organ allocation, and outcome in liver transplantation. In a DDLT setting, if you see, the organ has to be allocated to a very sick patients. To assess the severity of the chronic liver disease, CTP was followed earlier. In early 2002, once the MELD score has come to the application, it showed that tremendous improvement in the post-liver transplant outcome, and it's significantly reduced the short-term mortality in a decompensated chronic liver disease. If you see the evaluation of the MELD, after the MELD, there are so many modifications, various studies, MELD sodium, delta MELD, integrated MELD, MELD plus, and MELD with GFR, MELD with cystatin C, and MELD with lactate. So many the papers has been come out, but almost all focused on which the scoring system will be the good predictor to assess the short-term mortality, because that time we can allocate the organ properly to the sick patients. But at present, in and the worldwide, MELD sodium is one of the best predictor, not only in US and Canada, in European countries, except Europe. Europe still following the UK ELD scoring system for organ allocation. And I will come to the later on MELD 3. So, even though this kind of the various types of the MELD scoring systems are there, what is the beyond MELD? If you look into that, almost all the MELD scoring systems have the cap of 40. The score is 40. But this is the one study, Nadim et al. Following that, there are so many papers on above MELD. Suppose if they divided this one divided 3 classification, 41 to 44 MELD one group, 45 to 49 and 50. So this detailed study shows almost those who have the MELD 50 compared with the MELD 39, almost hazard ratio was 5. So now it's very clearly shows. So we can extend beyond, because our idea is to allocate the organ to the very, very sick patients. So instead of 39, we know the short-term mortality goes to close to 60. But if you compare with the MELD 50, it goes up to 83%. So that's why. So if you see this, the last one, post-liver transplant outcome is almost good compared with the MELD 39 and the MELD 50. So MELD 50 shows it is a very poor outcome without liver transplant. Even though the patient is very sick, by undergoing transplant, outcome is equally effective. This is the graph shows all the numbers what are focused on MELD more than 40. So the number of the inner liver transplant centers. So the MELD 40, the number of transplant patients undergoing for the surgeries are keep on increasing. And if you see 41 to 44, and the red shows the 45 to 49, the green shows the 50. So this clearly shows, if you take MELD 39, so this all the group will go to the 13 under the 39 group. So, but really these category groups need a yearly allocation. So now only it comes MELD 3.0. Here, apart from MELD NA, they added the gender as well as the albumin score. And this shows the category wise, not only this caps goes to 50. So now the MELD 3.0, it will be much superior actually at present, but need a validation, so many publications, to allocate the organ to the very sick patient, because identifying the who will be have the almost mortality, 90 days mortality come to more than 80%. Still, even though the MELD score is just based on the various parameters, but still we have a separate, we know the sarcopenia, it has an independent prognostic marker for the liver transplant. And if you see all the portal hypertension related complications, recurrent hydrothorax, refractory ascites, recurrent hepatic encephalopathy, recurrent SBP, or hepatopulmonary syndrome, portopulmonary hypertension. So all the complications have independent prognostic marker for assess the short-term mortality. But where we have to insert this kind of the markers, this kind of the factors into the routine MELD or MELD 3. So these are the real challenge to allocate which patients we have to, either recurrent hydrothorax patient or hepatic encephalopathy we have to allocate, or MELD based on 3.050. So these are the challenging. So we know the malnutrition is progressively increased based on the severity of the liver disease, followed by the sarcopenia. The sarcopenia related to the frailty. These all interrelated. So we know how to assess also. The sarcopenia how to assess, frailty how to assess, and there are more papers on the each, whatever I mentioned, CT, MRI, muscle mass, or a DEXA scan, and the thigh ultrasound, the TMT, thigh muscle thickness assessment, and bioimpedance assay, so many things, and here also liver frailty. So we know these are all the parameters or the findings will cause the more mortality in a severe liver disease, but we don't know how to allocate the organ, particularly in the DDLT setting, to give the prioritization. And the frailty phenotypes, there are 5 parameters we know, 1 to 5. 5 is the very sick, that all we know. And this frailty or sarcopenia, it's not uncommon. Almost 1/3 of the patients in the chronic liver disease will have. So there are more. So this is the paper from our PGA and SGPA. It's a meta-analysis of the prevalence of the frailty and its impact. Sorry. So here, this meta-analysis, I mean, almost 12 studies they have taken, almost 6,000 plus decompensated chronic liver disease. This clearly shows the mortality. This is all independent predictor of the mortality in chronic liver disease. Almost comes the overall 29, almost 30% mortality. So even in the low MELD. So this sarcopenia and the frailty is, and this is a Spanish paper. This are just I wish to touch. And there are we know the liver frailty index more than 4.5 is a very bad, poor outcome predictor. And not only the shorter mortality, if you are going to take the patient for liver transplant, post-liver transplant outcome also not good. So when to take the patient? So before to reach that stage, we have to allocate the organ. Otherwise, if a sick patient, we are giving priority to them to organ allocation, but the post-liver transplant outcome is not that good. So how to do all the things? So now there are the frailty with the MELD. So earlier I said MELD related all the things. The MELD plus with the frailty index paper came. So integrating, there is a formula, how and the application, and following that the sarcopenia also. No, it's not. Moving back. Yes. So the sarcopenia, how the MELD NA with the frailty, similarly the MELD score with the sarcopenia. There are if you see the last, so the factors wise, assessment wise, integration. So what about its a real application wise? So far there is no much paper following this. These are the studies they have shown, but if you look into that, practically the application, organ allocations, so far the things. Another entity, so far we have showed the decompensated chronic liver disease MELD. What about the ACLF? It is totally different. ACLF, we shouldn't do the surgery at patient when we are very sick. So there are the alcoholic hepatitis. we have to start the therapy, we have to see 7 days later Lilly score. If you see the Hep B related reactivation, 2 weeks, any logarithmic reduction is there or on Hep B, autoimmune flare, so steroid, and we have to follow it up. In the Wilson and Lilly, still the therapeutic plasma exchange is questionable, but in practically most of the centers are doing. And Wilson, of course, it shows the benefit. In other cases, still, so we have to follow the MELD score. So what is the not MELD score, actually the ACLF, CLIF C ACLF score. And we have to watch for the 7 days, and the improvement is there, then so this group, how we have to allocate the organ, this all in the DDLT setting, but in living donor liver transplant difference, okay, we can decide. So clear, so how we have to incorporate, and not only the CLIF C ACLF score, there are the various, and now the ARC score is showing the better to predict the short-term mortality. See, all the scoring systems aiming to predict the short-term mortality, 30 days mortality, or the 90 days mortality, so that time the outcomes. So now we know the urgency, to allocate. Another one is the utility. So that's why I said, we know to whom to allocate, but after the allocation, what about the patient survival? That is, if you allocate, which patient is giving the longest post-liver transplant survival? And at the same time, so we shouldn't do the transplant at the early also. These are the real challenges in the allocation policy. So, number one, the pitfalls in the organ allocation. So I told to defining the mortality and the futility. So we shouldn't allocate the organ to sick. And whatever the scoring system, various scoring system, MELD 3, etc., and MELD with the sarcopenia, MELD with the frailty, and the ACLF scoring system. So which one to be followed? And there are some MELD exceptions still. The portal hypertension related complication, whatever I mentioned, so how to give the priority. So before to conclude to my talk, so now the AI technology has formulated. Using the AI technology, the machine learning wise, there are so many things, papers are coming up, but I wish to quote here only one, the waitlist outcome and organ allocation. So this data almost more than 1 lakh of decompensated chronic liver disease. They have taken the 28 variables, because it's a AI machine learning is possible. So 28 variables, and the neural network, the model shows the better than the MELD score. So this is so not only the organ allocation, if you see, not only the liver transplant, this AI technology, machine learning wise, the allocation policy, not only allocation policy, post-transplant outcome policy, so they need to do that. So this is the separate area. So in future it's evolving with this, because us is the machine learning, so we can put more parameters, so large volume, multi-centers, centers join involved, the prediction will be much better. And this is already told. Sorry, it's not. Okay, 1 minute please. Okay, so this is the last slide. We know urgency of the transplant based on the short-term mortality, various scoring systems beyond MELD. At the same time, this donor risk index, soft and bar, this all we have to involve to give the better post-liver transplant survival. Otherwise, just allocating organ to the sick patient, and sometimes the outcome is poor, that's not the good model. So, ladies and gentlemen, MELD and its continued refinements keep on going on, and still the sarcopenia, frailty, malnutrition related, the mortality is independent, we have to involve, and there is a newer scoring system, ACLF, and portal hypertension and complication we have to involve, and AI system is coming up in a big way. Thank you so much for kind listening.